Welcome to this BTOG webcast and podcast. This is part of our ongoing series of BTOG webcasts, which cover all aspects of thoracic oncology, and I hope you're going to enjoy this one. And this is going to be about ESTRO 26, which was held just a couple of weeks ago in Stockholm in Sweden. Just a bit of housekeeping, just to let you know that the BTOG sponsors are not involved in any of today's content. Just to let you know, my name's Clive Peedell. I'm a consultant clinical oncologist from James Cook Hospital in Middlesbrough. And we've got two fantastic guests this evening. We've got Dr. John Conibear, who's a consultant clinical oncologist from St. Bartholomew's Hospital. And we've got Rebecca Pickles, who's a consultant radiographer from the Northern Cancer Centre in Newcastle. So we've got all our radiation oncology bases covered. So without further ado, let's start the meeting. What we felt we'd do is just have a general discussion, really, to see which were the most interesting insights from the meeting, and sort of start off by trying to cover early stage disease and then work on through the more advanced stages disease, locally advanced and metastatic disease, and also add in a lot of the sort of technical type aspects and also the pragmatic implementation aspects. So why don't we start off somewhere sort of close to my heart with the sort of single fraction stereotactic radiotherapy for early stage disease, and we'll start off with John on this one. There were a few abstracts and posters on this topic, John. What did you think about things, and is this really sort of an era that we should be moving into now?
Yeah, thanks, Clive. I think certainly in my practice, where I'm based in Bath in London, it feels as though there was a kind of spike during the COVID pandemic sort of era where minimizing visits to the hospital was clearly a focus of clinical need. And that seems to have drifted off, and our use of single fraction SABR, certainly where I am, seems to have diminished. And so it was actually nice to see in ESTRO this year sort of reigniting that fire. There was data presented from the Portuguese group, over 260 patients receiving single fraction SABR, sort of 30 gray, and the results they presented were really encouraging. So it was nice to sort of bring that buzz back to the radiation community about what we can achieve using single fraction.
Yeah, I think there was a few papers. I think there was another one. I was looking on sort of I was following the whole thing on Twitter at X. I was unable to attend the meeting, but there was a big group from Roswell Park and a few other centres that presented sort of over 1,600, and they were reporting local control rates in excess of 90% and grade 3 toxicity very low, sort of just about 3% or so. Was that sort of your experience, sort of low toxicity when you've been using the treatment?
Yeah, I certainly, the patients who I've treated seem to have done really well. Great local control, no significant sort of grade 3, grade 4 toxicities. Thankfully, obviously, no grade 5 either. And so, yes, I'd say that my experience to date is that it's been very positive. I'd say that perhaps patient selection has been a factor, and it's finding the right patient sometimes to come through the door. That seems to be one of the limitations to adopting it. So yeah.
Yeah, I mean, I think we do have to have sort of careful selection. There's been a bit of criticism of the UK practice that we're a bit too conservative from other places, because we did publish our guidance during COVID, and there's been a little bit of critique about that. But I think we're getting braver now, and I think we can treat, slightly larger tumours. We try to stay off the chest wall, those sorts of things. But there's increasing data, I think, that actually, as long as you're not on the chest wall, it's probably safe practice. I'm just going to come on to see what Rebecca says, just in terms of the, pragmatic approach to sort of delivering single fraction radiotherapy. I think there were some abstracts about trying to do it all in one day. What do you think about that, Rebecca? Do you think that's a bit of overkill? Do we really need to be going down that route?
I think in theory it sounds amazing. However, in practice, I think we just have so many patients, and as you know, there's so many steps in the pathway as well. So in our practice here in Newcastle, our slots are so important that we can't be wasting any at all. So, and also you've got to get it right, haven't you? So it's almost like you don't want to be under too much pressure. Sometimes, if you're not getting a 4D trace, or you need a peer review, or you're not quite happy with the dosimetry and you want it re-optimizing, there's not much room in the pathway to allow for that. A lot of our patients are quite frail as well. So some patients don't want to be hanging around the hospital all day, especially if they've got lots of other comorbidity. So actually, we did do an audit of this actually not that long ago, because we used to do a one-stop shop service, not for one fraction, but for multi-fractions, just to get them started. And our patient satisfaction questionnaires did come back where they just preferred having multiple visits. So actually, I think patients really have to have a choice in this as well. And considering, all the pressures in the NHS and in radiotherapy departments at the moment, I don't think we can waste any slots as well. And actually, when you break down the numbers, the 3-fraction SABRs, they're not actually that high. So what are we gaining? And actually, are these a clinical priority? What's the rush to get them through? So we've got to be really, really careful about selection, about competing priorities. And it's not just in the lung community, it's other site specifics as well in the radiotherapy department. So personally in Newcastle, we don't have anything to gain, but I appreciate everywhere's different. They might have the luxury of having facilities for patients to wait around all day, but yeah, not here in Newcastle.
Yeah, no, I think that's right. I think it sounds great, doesn't it? But I think it's a bit too cool for school, isn't it? In terms of the pragmatic approach, you've got one shot here. That's why people are a bit worried,
Yeah.
and you don't want to get it wrong. So why rush it?
No.
So plan it properly, take care. I can understand why if people are traveling a long way, but actually, certainly in Middlesbrough, people aren't coming from huge distances, and to come back the next day or a week later, it's no big deal. So I think it's probably it's a bit showing off really, and doesn't really
I
add
mean, we're
anything.
used to covering a very large geographical area, and actually our patients would rather travel. So it's one extra visit. And actually when they are here, it takes us 20 minutes to deliver the treatment. And we know we've got it right. There's no pressure, and the patient's expectations are being met. Because I think, if the patient's expecting it all in one day and then we can't deliver, we've let the patient down. And we wasted a slot. So we have to think about those capacity. And it means we can spend a bit longer explaining this as well. So I think that's really important.
Yeah. And another thing I think sort of with the integration potentially in future with immunotherapy into our practice, I think you picked up, we sort of highlighted a paper looking at multi-fraction, single fraction, and sort of how that interacts with potentially with immunotherapy. And actually it looks like the multi-fraction might be a better option rather than single fraction if we were going to go down that approach. Do you want to sort of summarize some of that?
Well, I suppose it's about, I guess it's in its infancy, and if it ever happens or if it ever comes through is a different story, isn't it? But I guess, this concept about a single very high dose fraction is about dominated by direct tumor kill and vascular injury. And what I guess the research is alluding to is potential reduction in innate immune signaling in TREX1. And the multi-fraction SBRT, I guess that is a better balance between tumor ablation and this immune priming as well. So it's more about an enhanced adaptive immune activation. So, I guess looking at a pathway point of view as well, it's where does it fit, and what do we do if patients are going to get this toxicity? And I guess there's a lot of unanswered questions. I'm sure John can emphasize a bit more on this as well.
Yeah, what do you think, John? Obviously, it's only in really its infancy, isn't it? Immunotherapy plus SABR, because obviously not all patients are going to be candidates for it, but it is generally better tolerated than chemotherapy, and there are some, iSABR type protocols and studies ongoing. Where do you think the future lies with it?
I think it's trying to unpick the kind of secret formula that we need to sort of understand better. It feels a bit at the moment that we have the different ingredients, but we don't know when to add them, what quantity to add, And as a consequence of that, we're seeing sort of mixed signals from different groups doing different studies using different fractionations, different immune modulating drugs. So, there's so much wealth of things that we can explore, so many different variables you can tweak, that I think it's probably good to start to think about what it is that we want to do. With a small peripheral lung tumor, if you just want to ablate and destroy that single site of disease, great. If you're looking to spark an immune reaction and look at sort of distant disease control where you perhaps have more nodal involvement, then I think it's about fractionation, perhaps, where you're trying to send off that immune signal and coax the immune system into sort of seeing what's going on further afield. And therefore, I think the approaches that groups need to take need really to think about what the question is they're trying to answer in the first place, and then build on top of that. Because, going back a decade, when I started, it was still a case of, well, do we use 3 fractions? Do we use 5? Do we use 1? Do we give immunotherapy with it? And I think we've seen from the sort of concurrent chemoradiotherapy studies that actually giving the immunotherapy when you're giving the radiation, you're recruiting your troops, but then you're bombing them yourself when they're all going in to sort of do the work you want them to do. So I think we have to perhaps be a little bit more thoughtful on what the answers are we're looking for, so that we describe the studies to get those answers more pragmatically.
Yeah, absolutely agree. I think the only one thing we can be certain on is it, like you say, giving it concurrently with a course of radiation. Don't give the immunotherapy at the same time. I think there's lots of evidence across different tumor sites now as well. So I think that's clear. But then whether you give it up front or afterwards, and how we actually do the fractionation of the radiotherapy is still a huge amount of work to be done. And the more you think about it, the more crazily complex it becomes. But yeah, on that note, I mean, moving on to some of the sort of stage 3 type stuff going on, pick out some of the interesting stuff. What did you think from stage 3 disease? I think there was a few studies, weren't there? There was let me just look. Star-Lord and Daedalus were a couple that we highlighted before.
Yeah, so there was clearly a lot of focus given on what do we do for the patients who are kind of borderline fitness, who aren't capable of withstanding the sort of traditional Pacific chemoradiotherapy approach. And so the studies that you mentioned looked at a more sort of balanced approach to sort of toxicity and outcome. So they used lower dose schedules, sort of 45 gray. They even looked at the potential role of a stereotactic radiotherapy approach to treat the primary and lymph nodes. And then, of course, there was the addition of systemic therapy, so concurrent chemotherapy with immunotherapy. And actually, I found that quite interesting because in my experience, it's the addition of the chemotherapy in that PS2 group that I find can be a struggle. So in the one study where they looked at induction chemoimmunotherapy before radiotherapy, I thought it was kind of interesting that they kind of went in with something that I perhaps might be a bit more cautious. And in fact, I think their results from the study did in fact reveal increased toxicity, perhaps as a consequence of that. And it wasn't immune related toxicities. It seems it was your more traditional hematological. So yeah, interesting.
Yeah, absolutely. Rebecca, you've actually got a stage 3 MDT, which is fantastic in Newcastle. So all of this sort of stuff coming along, frailer patients and assessing them in all these sorts of ways. I mean, what have you taken from ESTRO? And how are you going to implement that? What were the key things for you?
Key things for me are, I mean, we see a lot of frail patients up here. We do perhaps put more frail patients on concurrent. We have tried different ways. We've collected local data as well. And actually, we know that we do push some patients too hard, adding in that chemotherapy. So I totally do back up John. We've seen it in clinical practice. We sometimes might bail out when we've done 2 cycles and just stick to the radiotherapy, but frailer patients do really struggle. And actually, so I do wonder, upfront just radiotherapy for these patients and actually concentrating on a little bit more prehab as well, rather than just throwing all these treatments at patients as well. And let's face it, looking at different trials. It's a trial population, isn't it? And how does that apply to our population in the Northeast? So it all has to be based on local population, and it needs to be adapted, really. So any trial in the world is great, but adding it to your local population, and that's why we're really keen doing prospective and retrospective audit, is just to get a real grasp for real world data as well. But to be honest with you, I totally agree with what John's saying. The chemotherapy can knock some of our patients. And what is the end point? And this is where, again, we've got to measure quality as well. What's important to a patient, and looking at all options on the table.
Yeah, I think that's a real key point for these frail patients, isn't it? You know, with the chemotherapy added to radiation is just you know, potentially really toxic for them. Obviously, we've had this whole drive with the Pacific trial to give concurrent chemo rads, haven't we? But actually, then that's and we have pushed harder, and it was the right to do so, because actually, if you look at the you know, the variation in practice, there's clearly too much variation around the country, and some areas weren't being aggressive enough. And I think BTOG's helped in a great deal in terms of the whole education thing and that real drive to do it. But there's still going to be a big percentage of patients who are not fit for that approach. And you know, I think the combination of radiotherapy and immunotherapy without chemo is obviously a great area for exploration. Was there any other studies that you picked out? Was it just looking at sort of immuno and sort of palliative radiotherapy schedules, either you or John?
So you touched on a good one there, actually, the idea of using alternative agents. So they presented data, so the Converge trial, which looked at an agent, NBTXR3, which is a hafnium oxide nano radiosensitizer.
Say that again, John.
Essentially, it's a molecule that's designed to enhance radiation effects on the tissues that it's administered to. So patients essentially had this agent delivered intratumorally or via EBUS into nodes, and then they had their radiotherapy. And what they demonstrated, albeit in 7 patients, is an overall response rate of just under 86% and a complete response rate of sort of 57%, which does suggest that the agent perhaps makes tumor cells more susceptible to the damaging and killing effects of radiotherapy, and perhaps means that you may be able to avoid that sort of toxicity from traditional chemotherapy by using something that's sort of delivered into the site that you want to irradiate, you know. So, but obviously it's a signal, 7 patients. Let's see what the future holds, you know.
Yeah, I think Rebecca picked up that study as well. I saw that some of the
did,
discussion we
yeah.
had. Yeah, absolutely. So that looks quite exciting. And what about patient flows with that? Did you have a look at the details of how it was delivered and how that might affect day-to-day practice of radiographers? I know we're obviously some way away from that ever being a phase 3 trial, and but that's really quite exciting data.
It is. So, I mean, yeah, it's the pathway thing, isn't it? And this is where I think stage 3 MDT, you know, part of what we do is looking at the logistics and what comes first, patient selection. So, and actually, yes, upskilling radiographers as well and all the training that comes with it. So it's very exciting, but you wonder, when is it coming? Years and years away. And I think really we've got to think about, again, numbers are ever increasing, aren't they? And we've got to think about our resources as well. So John alluded to it before, patient selection is absolute key, and we can't treat everybody with these things. So yeah, that's all I really know about it. I mean, the complete response rate, fantastic, 57% versus less than 5% historically for CRT alone. But again, it's the numbers, 7 patients. So I don't know where this study is moving on to next.
Yeah, I think it generated quite a lot of interest, but yeah, absolutely, it'd be exciting to see what comes out of that, and how pragmatic it is to deliver, you know, etc. Just coming on to sort of some of the you know, protective type mechanisms in terms of new techniques. We're talking, there's quite a lot of talk about sort of lymphopenia and immunosuppression, all those sorts of issues, and there's a whole idea of maybe a flash radiotherapy might be able to, reduce some of the toxicity. I mean, I've heard a lot about flash radiotherapy. I don't know enough about it really. And was it big at ESTRO this year and big in the thoracic sort of discussions, or was it just on the sidelines?
So I have to say, I didn't personally see much in Flash. I think Astro last year, I would say I witnessed more presentations there. I think obviously we still and we're still learning to understand Flash and what it potentially offers our patients in future. I think the radiobiology and the principles behind it, it seems incredible. You deliver an incredible dose of radiation in literally a flash, in a sub-second period, and that sort of exhaustion of oxygen in that tiny fraction of time seems to be protective to normal tissues. And so that's the kind of concept I walk away with when I've seen it presented. The things that still pose a challenge is the design of the technology really to do that. And obviously treating the skin of a pig and treating the nose of a cat is all kind of hypothesis and evidence generating. But when it comes to treating a moving target in a human in the middle of their chest, I think there's still quite a number of hurdles to jump before we reach that point. But it's really exciting, and I find it, as an oncologist and as a clinician, it's great to see the science and see what the future may hold. So yeah.
Yeah. And do you know much about how linacs have to be modulated in order to do it? Is this something that is going to take an enormous amount of work on current linacs, or are these like experimental linacs in the various centers? Is it something that we're going to be able to introduce reasonably easily, or is this a real tough gig?
So I think, again, from the presentations I've seen, in terms of dose rate, you can get the dose rate up there with a sort of variant linac. In terms of the dose delivery, I think that's where it becomes a challenge. If you're treating surface targets like the skin, lymphoma, T-cell lymphoma, not such a problem. If you're delivering something where you want to deliver it sort of almost as a conformal radiotherapy approach, then you have to be able to deliver that treatment in all planes instantly at the same time, which almost means you need to have a sort of you need to have a 4-arm C-linac all pointed, yeah, so that you switch it on and it's delivered in that sort of single conformal. At least that's the concept I've used to try and understand it. So I think the technology is still being designed, Clive. I don't think it's
Yeah. I don't think we have to worry about it just too much yet, and we can listen to the expert groups and hear what they've got to say. But obviously, we need the data to follow it as well. But it's such an exciting field we're in, isn't it? Oh, it's just amazing what compared to when we first started, 20 years ago, etc. It's remarkable. So coming on to sort of maybe some of the stage 4 type disease. Obviously, there's a whole oligometastatic setting. There's treating the primary tumor. What sort of highlights did you have there, John, from some of the studies that were being presented?
So there were studies presented on the role of palliative radiotherapy, so sequencing with systemic treatment. We know that patients presenting with advanced disease are often symptomatic, and so there was the PRIM trial looking at introducing palliative radiotherapy before the patient started their chemoimmunotherapy. And I thought, that's a pragmatic and potentially useful thing to do, so as to avoid patients deteriorating while they wait for their chemo to start. I think that's a problem that we all experience, and perhaps as a group we don't perhaps voice as much. I certainly see in our practice in Barts, patients presented in MDT, they turn up at clinic and they're just, they're beginning to waver. And by the time the patient gets the slot on the day unit, unfortunately their performance status has sunk. And sometimes that can be from, I would say, reversible disease-linked problems, and perhaps injecting that radiotherapy into their pathway helps them to avoid that deterioration. Some of the things that I kind of left and thought about is, the dose 20 and 5, should it be more? Should it be potentially more stereotactic. We've seen data presented on using stereotactic radiotherapy for threatening bone metastases for pain control. And actually, it does seem as though it keeps patients better for longer. And perhaps that means they can have more systemic therapy for longer. And so these kind of signals that are coming out of the data are really interesting things, I think, to look at in future.
Yeah, I think that whole idea of sort of treating the primary tumor to sort of radical doses is quite interesting, and I think sort of it is like looking at that at the moment, and the sort of producing some guidance, something that's been published recently. And I don't think there's anything definitive there, but I think it's becoming increasingly something that people are considering in terms of knocking out those clonogens coming from the sort of primary tumor, and preventing the sort of where the metastases originate from, and I think that's going to be really interesting for the future to see whether the ongoing studies are going to show that that's the local consolidative therapy is the right way to go. We certainly saw that in sort of EGFR positive disease, didn't we? That was treating METs and the primary with the North Star, a year or two ago. So I think that's all to be developed, I think. Rebecca, you had a few abstracts and posters you're interested on the sort of stage 4 setting. Did any ones that stuck out in particular?
Well, that was more about the PRIM concept again, that I guess John's alluded to a little bit, but looking at the standard pathway and comparing it to the PRIM pathway again, they get diagnosed and then you give them upfront radiotherapy to the primary tumor plus or minus 2 to 5 metastatic sites, and they start the chemo IO, and then obviously they have an enhanced systemic response. So again, it was looking more at the biological part of it as well, and the potential abscopal effects as well. So I found that really, really quite interesting. It does open up this kind of worm, so because again, it comes down to, dare I say it again, capacity and opening up the floodgates, and we could be treating everybody, and it just comes back down to that patient selection. But I found that a very interesting abstract to read. And again, bringing in all the adaptive targeted therapies as well, and all the technology, and I guess using AI as well, because I know you're talking about all these fancy IO drugs, but it's all about actually the technology and delivering the SABR. We're reducing the margins, we're treating patients isotoxic, meaning we're pushing those doses up to the tumor but minimizing doses to organs at risk. So I think there's still a lot of data that we need, and even with the published data, I think it's still really important that we do our local audits just to ensure that we're doing the right thing by our patient as well.
No, absolutely. I think that's a real key point you made there about increasing indications, because we're so much involved across the whole spectrum, aren't we? Stage 1 through all the stages of disease, and like say, if we're to get involved giving say 5 fractions to all our stage 4 patients up front, that could cause like big influx, couldn't it? I think that's a real issue to be aware of. Obviously, we need the phase 3 data to confirm some of these interesting early it's really their pointers, I think, a lot of these studies, rather than practice changing at the moment. But if it was practice changing, then we're certainly going to have to address things. I mean, and on that sort of trying to improve workflows and things like that, because ESTRO's quite good at providing that sort of work as well from a radiographer point of view. Are there some sort of new developments that are going to help in patient flow through the departments and things?
I think we've got to think about AI. Let's face it, the reality is our workload is increasing. Our workforce is perhaps decreasing at the moment, but sustaining it, getting more staff. But we've got to use the software, we've got to use the technology, but it's got to be applicable to our departments and our population. I appreciate, in the north might be different to the south. We've got a lot of lung cancer up here. So I know all this talk about MR guided, radiotherapy and adapted radiotherapy, actually, from our department, that would not be very sensible, because we've got that workflow we need to get patients through. So you've got to look at what the technology actually adds, and we've just installed some hypersight units. So this is it's basically a next generation cone beam imaging system, where it produces really high quality 3D. So you can get your cone beams within 6 seconds, so absolutely rapid, and the images are superb. But you can actually integrate this with race station adaptive planning models, but it's just ensuring that the workflow is correct. So obviously you can do offline and online. So at the moment, we're just looking at proposed adaptive workflows, actually looking at a rapid offline plan where it'll be a fully automated monitoring of treatment dose. So, and we can predetermine dosimetric triggers that would initiate a replan. So, and this would primarily be led by our dosimetrists with clinician support as well. And then the online adaptive replan would be a highly automated online replan where this relies, it'll be a radiographer-led, but initially, obviously, clinician dosimetry. So again, though, it's about selection. So, and these for patients for those more complex plans as well. So at the moment, we're trialing it on, well, the proposed initial sites are head and neck, bladder and gynae. So lung will come after it because we've got to get those workflows in order. So actually, it's very exciting when you go to ESTRO and you see all the technology, but in an NHS busy department, it's not always appropriate or suitable.
Yeah, you often come away from.
You've got to come away, you're all excited, but, you know, when you're feeding it back to your manager, you've got to be pragmatic and, you know, we want the best treatments for our patients, but we don't want any delays. And it's about timely treatment as well.
Yeah, I mean, I think that adaptive stuff's amazing, and obviously you see it work with the MR-Linac, but actually with the amazing cone beams that we've got now and how quickly the images can be generated, I foresee with that, type of imaging getting very close to what MR-Linac can achieve in most sites, and certainly in the thorax. And I went to see an MR-Linac in action when I visited Washington University, St. Louis, and it was radiographer-led, the adaptive planning, and I really foresaw that as that's the way forward. The clinicians are busy in clinic, and you guys can actually do the adaptive planning. And obviously, it's going to take some training. It's going to take oversight and clinical governance. But for me, that's the future. And then if you add in the AI to help do the outlining, the planning, the guidance, and then get the patient having that adaptive treatment straight away. I mean, that's the future, isn't it? I think that's the way it's going.
Yeah, I agree. And actually it is, we're upskilling radiographers as well. As you're very much aware, there's 4 consultant lung radiographers across the country, up and coming ACPs. And we've been through thorough training with very tight scopes of practice, and it works in clinical practice. And we are best placed because we see images every day. We've got a good background of dosimetry, but it's about the governance, it's about the belt and braces, and it's about what works. And also patient selection is absolutely critical in all of this.
Yeah, absolutely. And John, down at St. Bart's, how are things going in terms of radiographer-led services? Obviously, Rebecca's a consultant radiographer up in Newcastle. She's got like an independent SBRT practice, and I think that's amazing. This is where I think some of our experienced healthcare professionals can, help deliver our service. There's a big arguments about physician assistants. That's a totally different thing to, the roles of consultant radiographers. And I see it as essential rather than a threat. How is it looked at down in in London, and in terms of your services and the future and all the new pieces of kit that you're working with?
Yeah, so I think we see it as the future. I think it's having site specialist RADs is critical, and Rebecca touched on the workforce where we are now is shaky, and unfortunately the current state of resources and funding, certainly where I am, means that business cases are just stuck at the start. Unfortunately, the money doesn't seem to be in the pot to sort of expand the workforce with those people with the expertise that would be really valuable to sort of strengthen the team and improve patient care and perhaps make the clinicians' lives, I wouldn't say easier, but actually allow us to use our skills where they're best used in clinics, seeing patients, and and shortening waiting times for patients to get into clinic. So I unfortunately just feel as though the resources at the moment are just not there, sadly, Clive.
Yeah, no, I feel that. I mean, up in Middlesbrough, we've been sort of hypofractionating everything. We've actually just gone back to COVID type SABR schedules, you know. So if it's on the chest wall, they're getting 3 fractions rather than 5 fractions. We use quite a bit of single fraction where we can. We are basically, in terms of our prostate as well, it's nearly all 5 fraction type work now to the prostate SBRT. So the common cancers like, you know, breast, lung, prostate, we're doing hypofractionation across the board, and it's but the elastic band is still stretched. You know what I mean? And they just want to do more and more and more with less and less staff, and it's just so frustrating. And you know, I think the technology will help, and I think it's there, but it's getting it across the line and convincing the management to say, you know, look, this AI coming in is really important. I mean, at the national level, there was the whole, you know, AI helping, you know, with outlining prosoma, all that sort of stuff, and the funding was cut off for a little while, but we said, look, you know, actually this is helping our dosimetrist, is cutting time enormously by having auto contouring. What you're doing, this is, you get more bang for your buck, and that's the key thing to get the message across. Keep using that term, more bang for your buck. They like that, and we will get that, you know, funding coming along. But it's just so frustrating, sort of banging your head, isn't it, to try and make the powers above see that actually it's a phenomenally cost-effective type of treatment, and we need to really be pushing the agenda to get the technology to allow us to do it even more cheaply.
The technology allows us to optimize, doesn't it? And if you think about it, the whole aim is to less toxicity for our patients, less admissions, less input, less intervention. So actually, it's a very good investment up front as well.
No, absolutely, and I think that's a role for, you know, for all of us, for the advocates in BTOG and all the committees that are on to sort of push the agenda. I know the various societies are trying to do that, and I think it's absolutely key that we continue that. So I think we're done a good session already, actually. So why don't we just have maybe give us your sort of 3 top things that you learned from the meeting. Should we go ladies first? What do you think, Rebecca? So just maybe your top 3 things that you think might change practice, or even if they don't change practice, they're really exciting.
I think just all the adaptive therapy. I mean, all these toys to play with, let's face it. You know, it's really exciting. As a radiographer, we love technology. We love AI. If we had all the money in the world, I would love, you know, a few research linacs, you know, adaptive therapy and MRI linac. Also AI as well, you know, integrating more software that, you know, auto contours and yeah, there's so much to choose from, really. And actually, it was really interesting, all the frailty stuff as well. I think, you know, it's important that we do still, you know, I guess, don't lose hope in all the current climate, because we've got to keep pushing things forward. So just that the PRIM concept as well is quite exciting, whether it ever happens. As we know, metastatic patients can live a long time as well, and cancers change, lung cancers change in young, fitter people are getting it. So it's actually having equal access for all, isn't it? So I was quite excited by that, but in reality, yes, have to sit back.
Yeah, that's a great you know, overall summary, and that's what we're all trying to achieve. You know, that sort of equity of service across the board with such a heterogeneous, you know, group of patients. But you know, lung cancer is turning into a chronic disease now. You know, with the and being able to, you know, as clinics, we train in radiation oncology and medical oncology, and it's actually originally seen, oh, that's a pain, but actually it's a blessing in disguise, and I think it's the future. What about you, John? What were your sort of highlights, and what you taking anything back to change your practice?
So I think personalization. So I think I came away thinking about the stage 3, stage 4 patients. So we talked about Star-Lord and Daedalus, and how being more systemic therapy aware in patients who are borderline fitness. So just not forgetting about those patients who aren't fit enough for radical concurrent chemo rad, but actually the ones, and there's a lot of those patients around, where actually personalizing their radiation, personalizing the sort of the pathway in which they're going to be on, hopefully will get them through to the other end with clinical improvement in their disease. The other thing was so toxicity sparing. So I don't think we touched on it, but there was actually some really interesting data on cardiac sparing. So, and that's something which I think we can all take away and take back to the planning that we do. Think about where the rays are going. And if they don't need to go through the heart, don't put them through the heart, because your patient will thank you later. And that was certainly a message that I kind of have taken away with me. And then probably the last one is, and actually it's on the industry floor. So going into the industry booth and seeing what the manufacturers are doing with all of the things that we've perhaps touched on today, you know, improving workflow, utilizing AI safely, and giving us the tools to treat our patients with less toxicity, more dignity in shorter periods of time. But unfortunately, it comes back to that all-important cost. And of course, the technology that they demonstrate isn't free, I'm afraid to say. But, you know, that's hopefully what we can build our business cases and demonstrate more bang for our buck using these new technologies in future. So, yeah.
Yeah, no, thanks very much, John. I want to thank you both so much for your time. Really enjoyed it. I mean, there's so much to try and summarize from a meeting like that. You know, I followed it online, and there's just a crazy amount of stuff coming out. So thanks for helping to, you know, pick out the sort of most important stuff. I'm sure we've missed loads, but that's just the nature of it. And no, but I just want to thank you both so much. It was a brilliant conversation. Really enjoyed it. Hopefully we'll do it again one day. And hopefully we can get some of that kit and some funding of it all, and so that we can play with these amazing toys for the benefit of patients. That's what it's about. So I think I'll close it there, and I'll just say that thanks for everybody listening in, and this will be recorded. It will be available on the BTOG website, www.btog.org. Brilliant, I remembered that. And there'll be instructions how, if you're not already a member, how you can sign up to be a member of the organization. So yeah, please join the BTOG family, and all the best, and good luck to England and Scotland in the World Cup.